and welcome to this Clinical Care Solutions Oncology podcast. We hope you find this podcast informative and valuable to your daily practice. Now, let's get started.
Hello, everyone. I'm Phil Muskin. I'm a psychiatrist at Columbia University in New York City. And thank you for joining me today to talk about depression in patients with cancer and an overview of depression, some thoughts about treatment, etc., over the next half hour. This quote by Maudsley, I think, summarizes everything that we know as physicians in terms of depression. You know, when patients are unhappy all the way through meeting diagnostic criteria for depression, it is often not just an emotional experience. That is, they feel unwell, they have aches and pains, their sleep, their appetite changes. And of course, if you take care of patients with cancer, I've also described many of the symptoms that patients with cancer complain about with or without therapies for cancer. But I think it's important to keep in mind that depression is psychological or psychic disorder and a physiologic disorder. And so it may express itself, and we'll talk about that in a few minutes, purely physiologically with very little in the way of psychological symptoms. But let's start with the depressed patient. And when should we think about someone who's depressed, particularly in the medically ill patients? We'll talk about some of that data in terms of percentages in a bit. One of the things that I think is very key if you treat patients, any patient, doesn't matter what your endeavor is, and the patient is sad, is we as physicians know there is some balance between what the patient has and what we know the course of that will be in terms of the illness or the treatment of the illness and how much sadness the patient has. And there's a certain amount of correlation that we expect, that we see with patients over the time that we have treated patients over the years. When that's not in keeping with what you know to be true about this illness, that should make you think about depression. Constant crying. Now, patients certainly cry when they're ill, but the patient who's crying every time you see that patient, the family tells you the patient is crying all the time, that is not common in patients with just a medical illness and without depression. Certainly, and we'll talk a little bit about suicide because I think it's an important evaluation to do with all patients. Patients who are talking about wanting to die, and it's unclear to you, why would someone want to die with this level of illness or given what you know about the prognosis, even if the prognosis is that the patient is likely to pass away in the next few years? Why is the patient talking about wanting to die now? As I've alluded to, when there is hope and the patient is hopeless, and that really does not match what you know about the illness and you know about the prognosis of the illness, that again should make you think, what else is going on here? Patients talk about being guilty. They may talk about being guilty that they have cancer. What did I do in life? And they'll have something. I was a bad person. I shoplifted when I was a teenager, on and on and on. That doesn't cause cancer. But when people start talking about guilt in terms of being treated or having cancer, again, it's something to think about. What else might I be seeing? Patients who refuse treatment. Now, in the setting I work in, which is I'm a Consultation-Liaison psychiatrist, we see patients who refuse all kinds of treatments from rather minimal all the way up to life-saving treatments. And it does make us always consider, why would somebody refuse a reasonable treatment, even given the risk balance that sometimes the risk is higher than we'd like, but the outcome is likely to be very beneficial. It should raise the question, not necessarily of depression per se, but what else is going on. Certainly patients who convey the sense that they feel worthless or inadequate along with the medical illness. If you think about that for a minute, why should anyone feel worthless or inadequate with a medical illness? That again would make you think something else is going on. Patients do talk about cancer as a punishment for bad deeds. Susan Sontag wrote about this beautifully years ago. And that should always start an inquiry, not necessarily to see a psychiatrist, by the way. Well, tell me about that. Help me understand that with you. And then changes, any of the physiological changes that you know are not really connected to the illness. because you know the illness, you know the medications you're prescribing for the illness. So changes in the vegetative signs of depression, sleep, appetite, changes in energy, changes in concentration, memory, changes in sexual activity or sexual thoughts. And I think a very important, though it's not a criteria for depression, thing to think about is, you know, the quality of care you're delivering. You know what's going on if the patient is an inpatient on the unit. You know your healthcare setting. Patients who are complaining, but you know that the care they're getting does not match their complaint. Now, maybe they have a personality disorder. That's certainly a possibility, but it does raise the question, is this patient depressed? Let's talk about numbers a little bit. Depression is a common illness. The lifetime risk for depression is around 17% for the entire population, always higher in women than men for reasons that aren't particularly clear, but certainly known epidemiologically. So if you just go into the community at any one time, between 2 and 4%, almost as much as 6% of people will meet the diagnostic criteria for a major depressive disorder. And we'll come back to what that means in terms of patients. It's higher in primary care settings. It's higher in inpatient medical settings. And of course, that makes some sense. But also we have to keep in mind how these studies are done, what questionnaires are done in terms of how accurate is the data. But I think in an impressionistic way, depression is more common in all medical settings and in all medical illnesses. And you can see that in medically ill patients, a substantial number have a high prevalence of recent psychiatric illness. Now, we know for psychiatric patients, there is poor access to medical care. So many of the patients that have psychiatric illness have chronic medical illness because they're not getting the medical treatment that they need. And we know that medically ill patients, when you look at them epidemiologically, have this high, almost 25%, a little more, have a history of major depression that is the illness depression. And let's keep in mind, major depressive disorder is an illness. It's a medical illness that affects the brain, and it is a treatable illness and is important to treat as any other medical illness, hypertension, diabetes, cancer. It is a treatable illness, and we'll talk about that in a little bit. So now if you cone down a little bit, you can see, not surprisingly, that in chronic illnesses that have an impact on people's lives, multiple sclerosis, stroke, cancer for sure, Parkinson's, diabetes, etc., that major depression is common. And we'll talk about the impact of major depression on mortality in cancer patients. But we know in patients who've had myocardial infarctions, depression following a myocardial infarction, and not just sadness, diagnosable depression increases the mortality rate by 3.5 times in the next 6 months. That is considerable. Does treating it matter? That's somewhat up for grabs because the data is okay, but not great. But it certainly suggests that patients who are depressed following an MI should be afforded psychiatric treatment, be that psychological treatment or pharmacologic treatment. If we cone down now into cancer, you can see that the overall rate is just about 13%. Now, that's higher than the background rate in the population by almost a factor of 2. So it's not surprising, but again, as Maudsley said, that the organs may reflect the depression more than the mood reflects it. Women, as in all disorders, in mood disorders, except for bipolar, always have a higher prevalence around this 2-to-1 ratio. And women with lung cancer have a very high rate. Lung cancer is a serious illness, but that doesn't mean it's not treatable. They have a high rate. And not surprisingly, this is a meta-analysis. Younger patients have higher rates of anxiety and depression than do older patients. And part of that is that for younger patients, the experience of cancer is much more disruptive in an active young person's life, somebody with children and older people, not that they're better off, but they may be able to put cancer and their own mortality in a different perspective than a younger patient. So in terms of how one would think about this, it's worth the inquiry with every patient to find out about how they're doing psychologically and ways of asking about that we'll talk in a bit. How do you inquire about this? But I think that it becomes especially important to not just presume that someone is depressed and not presume that they're not, even if they say that they're not, and make that inquiry. And I think the inquiry, quite frankly, is very different when it comes from the doctor taking care of you than the psychiatrist. I like psychiatrists. I am a psychiatrist, and I think we do a great job. But when the person who you rely upon for your medical care enters into a discussion, and it doesn't have to take hours, it can take minutes, it really feels different. It feels that you're reaching out to this patient to inquire about how they're doing psychologically, including saying, some people feel depressed with this, tell me about it. Here is, just as is the case with myocardial infarction, the data on mortality in patients with cancer. So this is 76 studies that were subjected to a meta-analysis, and the increase, the relative risk was 1.17. You can say, well, that's not a lot, but it's not nothing, right? And you can see that the 95% confidence interval was always over 1. It was never below 1, and it was highly significant. What does that mean? It means that not addressing the potential that a patient with cancer has depression may alter their prognosis. And of course, we want every patient to do as best as that patient can possibly do, given what we can do with science. Now, one of the issues that always comes up is, well, how are you making this determination? Are you using a structured instrument, which most people don't use? Are you using diagnostic criteria like the DSM-5 or the ICD-10? That is categorical. You have it or you don't have it. There are a certain number of criteria you need to meet to have a diagnosis of depression. For the DSM, pervasive sadness, most day, every day for a period of 2 weeks or more, or a loss of interest in typically pleasurable or enjoyable activities, the same thing, most of the time for 2 weeks, plus 5 out of 9 other symptoms, including guilt or worthlessness, suicidality, changes in concentration, changes in appetite. Then you can see when you start doing it that way, well, a lot of what we do with patients can cause those symptoms, and we'll talk about that in detail in a minute. But that's diagnostic. Dimensional means from one end to the other, someone who has 0 symptoms, someone who has all the criteria-based symptoms. And what it turned out to be is it didn't matter. It didn't matter if a diagnosis of depression was made, that is, categorical yes or no, or dimensionally, that is, people having more and more of the symptoms, which may not always be sadness. It mattered not a bit in terms of the mortality connected to having depression. So that means a casual conversation is going to yield as much information as having a diagnostic instrument in your hands. Instruments such as the Beck Depression Inventory, the PHQ-2, which is basically criteria A for depression. Have you been depressed most of the day, every day for the past week? Or have you lost interest in activities, again, for the week? And answering those questions with yes most of the time is essentially diagnostic of depression. Man, that takes about 30 seconds. This comes up a lot, right? People say, oh, primary care physicians miss depression. Well, it's really unfair because when a patient comes into your office and says, I'm very sad, I feel hopeless, I don't think you can help me, I'm afraid I'm going to die, I'm afraid nothing's going to work. And you're thinking, this is a treatable disorder. You're going to be fine. You don't miss that the patient is depressed. 6% of these patients presenting with psychological symptoms get missed in a variety of primary care settings. The reality is most patients don't come in and say, I feel sad. I've lost interest in activities. They say, I feel tired. I have lost my appetite. I have aches and pains. I have chest pain. Well, that presentation makes it a lot harder to figure out is the patient depressed or not. And you can see that half of those patients in primary care settings get missed. In my setting, patients are sent to me because they are depressed. So I don't miss very many patients who are depressed because that's the reason they're there, even if I do the inquiry and say, maybe you're not depressed. So I would not say, let's put everybody on antidepressants because antidepressants don't work in people who are not depressed. So having a good sense yourself, getting a psychiatric consultation if you feel that that would be valuable to you, and making a diagnosis is important, because otherwise putting patients on antidepressants, and we'll talk about some of the interactions that are important. People don't get better if they're not depressed. They just get side effects, or the drugs cause interactions with the chemotherapeutic agents that are used and lower their effectiveness. So differential diagnosis, and you can see that in the middle column, everything looks the same, right? No matter what the cause of the symptoms are, depression looks like depression. That is fatigue, sadness, apathy, loss of energy, etc. But we have to always keep in mind when patients present that way, could this not be a major depressive disorder, that is an affective illness, but could something else be causing it? Certainly substance use disorders cause it, and then getting a history, including a family history, sometimes getting urine and blood screens may be very important in terms of determining that. Schizophrenia, you're certainly going to see patients who have cancer and schizophrenia, but you're unlikely to see patients who are early on in their schizophrenia, because schizophrenia starts typically when patients are rather young, late teens, early 20s. And so it may be hard to tell for a psychiatrist, is the patient depressed or schizophrenic? And many schizophrenic patients, when asked, do you have anyone giving you a diagnosis, they'll all say that they have depression. They never say schizophrenia. I don't think it matters in terms of treating them, though we know that patients who have psychotic disorders may be more vulnerable to not get access to care. Anemia, without question, anemia presents with fatigue, apathy, and it can look like depression, but we can check for that. We can check iron stores. And if you see patients with restless leg or akathisia, check their iron stores, because until you restore their iron balance, their restless leg's not going to get better. And low iron stores also cause insomnia. Again, one of the symptoms of depression. All endocrinopathies can make you manic, can make you depressed. It's a very interesting thing that disturbances of the endocrine system can cause, in a sense, bipolar disruptions of mood. And it's certainly worth thinking about in patients who have cancer. Could they have something else going on? And neoplasia, which is the way I put it together here to be very generic, certainly patients can present looking depressed, but they have cancer. That may be paraneoplastic symptoms of lung cancer, ovarian teratomas, seminomas, or testicular cancer. They may have an autoimmune phenomena that looks like depression, but is in fact secondary to the neoplasia. And until the tumor is removed, nothing will make that patient's depression better. And that we know there's very robust data on those autoimmune disorders. Medications, a lot of medications can make patients look depressed. Reserpine depletes the brain of neurotransmitters. 15% of patients on reserpine, we don't use a lot of reserpine, look depressed. Well, neurotransmitters are involved in depression. Corticosteroids can make people look manic, can make people look depressed. Beta blockers, there's always been some controversy about beta blockers, but certainly if you put a patient on a beta blocker and the patient starts to look depressed, think about it. But typically that is primarily associated with propranolol, because that's the only one that gets in the brain. Progesterone, again, all hormones, benzodiazepines maybe, and then chronic illnesses, trauma to the brain, and Parkinson's and Alzheimer's disease all can have presentations that look like depression. So things that might suggest a depression along with a chronic medical illness, and as I talked before, that can certainly look like a depression, but it may be secondary to the medical illness, or it may be depression superimposed upon the medical illness. So these on the left side are the symptoms we all know. But when you reassure a patient, now looking at psychological factors, hey, you're doing well, and the patient comes back to you with, I don't think so. That, I'm depressed because I'm not doing well. The patients who have chronic pain, but there really isn't a reason, complaints that really don't match what's going on medically. And patients with sexual dysfunction, many patients, no matter how sick they are, they really still want to have sex if they can. That would make me think of depression. There are a variety of psychotherapies, and psychodynamic life narrative, which I put in here, which was put together by Milt Biederman and Sam Perry at Cornell and Memorial. That's something that really only psychiatrists can do. It's an interesting therapy of saying, how did you get here in your life? Dignity therapy created by Harvey Chochinov in Canada, more targeted for patients at end of life. And meaning-centered psychotherapy, which is based on Viktor Frankl's work created by Bill Breitbart at Memorial, really is appropriate for actually all patients who have cancer who are interested in psychotherapies, not just for patients at end of life. So I'm only really going to talk about meaning-centered psychotherapy because patients who have cancer who are depressed may take the view, my life is over, my life had no meaning, and feel highly demoralized and unhappy. And so this is a kind of therapy that isn't just for the last few months of life, but a therapy that can really restore and preserve patients, even those patients who have a kind of cancer that will end their lives through that period of time. This has been studied in randomized controlled trials. And as I mentioned before about mortality and cancer and depression, it did not matter if the patients met diagnostic criteria for depression for psychotherapies, unlike pharmacotherapies. And so the Diane Meyer, who many of you may know, when she looked at patients making requests to end their lives, many were depressed, many had loss of meaning in their lives, and that's where psychotherapy may restore that. In addition, if the patient is depressed, we know that that correlates highly with the request for assisted death. And again, when the patient is depressed, then a medication will work. Just briefly about suicide. This is something I think we have to inquire about with all of our patients. And it is not difficult to do. And we know with robust data that bringing it up with the patient actually lowers the probability of them making a suicide attempt. And so you have to go over these criteria in your head as what might be operative with this patient. Very quickly, you ask a patient, have you ever thought life was not worth living? Well, I'm sick now, I'm going to die of cancer. No, you have cancer. We're treating your cancer. Have you had thoughts about actually hurting yourself? And if so, what would you do? Patients may say, oh, this is terrible. You'll think terribly of me if I say this. You say, no, I won't. I actually want to know this to help you with it. Contracts for safety, they don't work, but you do have to help a patient's family, often in concert with a psychiatrist. If you have this thought, what would you do? So to end and then have some discussion, antidepressants don't work if you're not depressed. So keep in mind, if you're treating the patient, and certainly if you're using a psychiatric consultation, the patient actually has to have depression to benefit from these drugs. That said, the drugs are really very good and help a lot. And the reason I put up these caveats are really to just keep in mind that many antidepressants interact with hepatic enzymes, and hepatic enzymes metabolize chemotherapeutic agents. So tamoxifen is very much affected, certainly by both fluoxetine and paroxetine, which paroxetine is Paxil, fluoxetine is Prozac. Citalopram, escitalopram, and the SNRIs such as venlafaxine don't really interact with the chemotherapeutic agents at all. High-dose sertraline may, because it, again, impacts on enzymes. And in terms of what's called complementary alternative integrative medicine, the one to keep in mind is St. John's wort. It does really impact on the liver, and patients may not tell you about this because they think, well, this is alternative. Does the doctor really need to know about this at all? And so I would ask, are there other things you use, herbs, nutraceuticals, et cetera? Because that's important. I know you use that to maintain your wellness. And so I always like to inquire about that. I've written a few books about it, but that's not why I inquire about it, because I know that there are drug interactions with it. And this was actually studied at Memorial some years ago in women with breast cancer. And those who turned to additional complementary alternative treatments were women who were more hopeless and less optimistic about survival. So if you have questions, certainly put them in the chat because I'm happy to answer any questions. And I'm watching the chat now to be sure that I'm not missing anything. The thing about antidepressants is you don't need to be a psychiatrist to prescribe antidepressants. And so they're not difficult drugs to use. So somebody is asking a question, Jamie is asking a question, What other psychiatric comorbidities do we see in cancer patients, and is the treatment the same? Keep in mind that if you have cancer, it doesn't mean you can't have other illnesses. You can have obsessive compulsive disorder. You can have depression. You can have anxiety disorders, not just being anxious. In terms of the treatment for the disorder in the face of cancer is the same as the treatment for the disorder absent the cancer, keeping the slide that's up in mind. That is, the drug interactions have to be kept in mind. And also keep in mind that serotonin reuptake inhibitors have an impact on sexual function, desire, arousal, and ability to orgasm. And if that's a function that's maintained in the patient, you have to think about what drugs can I use, and you have to talk to patients about this. There's another question about, can depression cause scoliosis? I'm not aware that that can happen. And a question about St. John's wort. St. John's wort is popular. Why is it popular? Because it's perceived by patients as not being a drug. Now, it is a drug. Yes, it comes from a plant, and hypericin comes from a plant, but they don't perceive it as a drug. Therefore, they're not taking it for depression. They're taking it for wellness. I'm a psychiatrist. I tried to remove the stigma of depression by saying this is a medical illness. And if you're using St. John's wort, that just guides me in terms of the treatment. I'm going to go back a couple of slides because there's another other question about SNRIs. SNRIs, so there are two SNRIs, right? There's venlafaxine, brand name Effexor, and duloxetine, brand name Cymbalta. Venlafaxine has no impact on the liver and very little protein binding. Duloxetine does have an effect on hepatic enzymes. So yes, if you're using duloxetine, keep in mind that it's a popular drug because it's also used for neuropathic pain, but it can impact on tamoxifen for sure, and drugs that go through 2D6. So a really good question. Thank you, Amin, for asking that question, because they're both SNRIs, that is serotonin, norepinephrine reuptake inhibitors, but they do have different impacts on the liver, and that's going to count for patients who are on chemotherapeutic agents. Well, thank you so much for joining me today. I hope that this was informative for you. I hope it was enjoyable as well. Take care.
We hope you enjoyed this podcast, and thank you for tuning in. Make sure to subscribe to the Clinical Care Solutions Oncology podcast, available in over 14 platforms, so you never miss an episode. Podcast episodes are also available on www.clinical-care.org under our Resource Center. Thank you for listening.